Good evening, everyone. Today, we are going to start a webinar. We are, as Spice Route Sri Lanka, Young Doctors Movement. Today, we are going to commemorate the World Mental Health Day 2024. Our theme will be the mental health at work. The common presentations at GP practice. So we would like to present eminent speaker, our psychiatrist, Dr. Prabhat Vikrama. My co-moderator will introduce him. My co-moderator is Dr. Supipi De Silva, one of the council members of our YDM Sri Lanka. And she's working as an MOH in our Colombo North region, and she's doing an eminent GP practice in Negombo area. So I would like to introduce Dr. Supipi to give some descriptions about our speaker today. I would like to invite Supipi to start on our webinar today.
Thank you, Dr. Praneeth. Good evening, everybody. Today is the World Mental Health Day. So the theme is mental health at the work. As a general practitioner and the committee leader, it is so important and responsibility to make our working environment safer. So we can aware our working population on mental well-being to empower them and to reduce the stigma. So today we select Dr. Prabhat Vikrama, consultant psychiatrist at District General Hospital, Negombo, as a resource person. Dr. Prabhat Vikrama is a good clinician and he involves with many activities, not only the Gampa district and also in the Sri Lanka, as happy school programs in Sri Lanka. So I cordially invite Dr. Prabhat Vikrama to continue the webinar. So over to you, sir.
Good evening. Thank you, Nisha and Sukuti, for inviting me. So, actually, as you know, mental illness carries a very big burden in the world, global burden of diseases. Mental illness comes, several mental illnesses comes in the top 10. So, only way to reduce this say the mental health gap is through the primary health care services. So as such, I thought discussing some presentation. So you will be able to diagnose them at your general practice and treat them. Then 18-year-old Pragi is brought in by parents, complaining that the school performances have deteriorated over last 6 months. He is confined to room and refuses food, mostly on phone, and gets angry with him. So, most important thing that in this history. So there are some key areas that he's 17-year-old. So that's one key area. School performances has deteriorated over last 6 months. So there's a clear onset for his symptoms. And then the phone comes in and then there's a symptom gets angry easily. So I think one aspect that we see there is this clear onset. So there is a clear onset of his symptoms. So this is, we are not talking about something chronic, that's like a personality issue. or say a development early age. So as there's a clear onset, recent onset, our differential diagnosis becomes much smaller. So let's discuss about this some key areas. So he's a teenager, 17 years old, a teenager. So many of you will be having kids as teenagers, and you will know that it's challenging to work with them. Teenage years are a time of transition, and the key thing is that he has say comes to the age of 20 or 20, early 20, they should have an idea who they are. So the parents' challenge is to make sure that their child become independent and identify themselves when they are young adults. So parents, now our parent era is different from our parents, and it has transited from very quickly from say late from the onset of the new millennium. The kids have trans the chance of kids from the mobile phones and internet, it has been very rapid. So parents need to be more understanding, supportive and friendly, and we have to understand this can't change the time. And the next one is the over the last 6 months. So there's a recent deterioration. So now what comes into my mind is whether this is secondary to an stressor. So whether this deterioration is due to an stressor that can be a loss event or a threat event. So loss event means has there been a loss, like a relationship problem, or a threat. So like he fails in exam, or he's getting the insight that he won't be able to do the exams as he expected, or the parents are expecting, or whether this could be a mental illness. Phone. So phone is for young people or even for adults. It's a way of coping now, and it's a way of
So we
relaxation.
can't hear properly.
You
We
can't
can't hear,
hear?
sir. Yes, sir.
Oh, okay.
It's not loud enough.
Dear sir,
Can you
may
hear now?
you may stop sharing your video, and you may go on with your voice only, sir.
Pardon?
Sir, bandwidth of your connection could be somewhat low. So you may stop your sharing your video, and you may proceed, sir.
Okay. Can you hear now?
Yes, sir. Now bit clear
Yes, sir.
than before. Yes.
Better, sir, better.
Okay, so do you want me to go back to the previous slide?
Yes, sir.
Okay, now the presentation is 17-year-old Pragi, brought in by parents. School performances deteriorated over last 6 months and is confined to room, refusing school, mostly on phone, and gets angry easily. So, as I said, the salient features are that she's a teenager, and there's a clear onset of the symptoms like over the last 6 months. And the phone is there, and the symptom is he gets angry easily. So, I'll discuss about this teenager thing a bit. Most of you may have teenagers as children. Teenagers is a period of transition. They are trying to identify themselves. And now our parenting challenges are different from our parents. And we have to be more understanding and supportive and friendly. Especially, we have to understand that our children are facing a different environment than us. And there's onset, so the last 6 months, that means we have to think whether there is a stressor in his life. So the stressor can be a lost event, like a relationship problem or a threat. Usually the threats are exams, where they understand all of a sudden that they can't reach the expectations of what they were expecting or what the parents are expecting. Or this could be a mental illness. So this recent deterioration is a significant thing. And phone for kids or adults, it's a way of coping or way of relaxation, recreation, or it could be an addiction. Can you hear me now?
Yes, sir.
Okay, so I will just go into parenting styles. There are 4 parenting styles: the authoritarian, authoritative, permissive, uninvolved. Authoritarian parents they are very strict, and the child just obeys. And if the child disobeys, that lead to punishment. But this parenting style leads children with very low self-esteem. The children are shy, they are less flexible, and sometimes they are very aggressive or they have very poor coping. So if you are authoritarian parent, you have to just think what my goal is, what my objective is. Whether my objective is to have a child with high self-esteem or just a child who obeys me but then fails when he faces a society. Then we have the authoritative parenting, that's the gold standard of parenting, who give clear guidelines but give allowances for discussion. And they respect child's input and transfer responsibility to the child. So that both parties are involved. And these children, when they are given responsibility and giving them clear guidelines, they develop high self-esteem and they become independent and they are more emotionally mature. Then the permissive type, they are very warm, nurturing, with minimum rules. So these kids have self-esteem, social skills, but they are more demanding, impulsive, and selfish. Uninvolved parents stay out of the way, and they only provide material. Apparently, these kids are more resilient, but they can't build relationships and can't control emotions. So I think all of us should think about what our parenting styles are and think what we expect from our children, say, after 10 years of time. So going back to the case, as I said, recent deterioration suggests a recent stressor or a mental illness. So recent stressor will lead to a mental health problem, like a loss of relationship, exam, bullying. They are usually transient. So you have to just talk to the child and see what he's facing. And then supporting him, counseling him, giving him advice will resolve the problem. But then it is not as such in mental illness. I strongly suspect that the case I presented, the child may be having depression. So mental illness are due to predisposing factors. So the predisposing factors are where they are genetically predisposed, and then or they may be having a difficult childhood due to parents or social problems. And if you are predisposed, and a precipitating event will lead you to a mental illness. So the mental illness can lead to changes in emotions, thoughts, and behaviors, and it is more permanent, and you have to treat it. So, 2 mental illness I would like you to know or understand quite well is depression and anxiety disorder. I mean, any general practitioner should know what is depression and what is anxiety disorder. But whether you are built now, when you come to mental illnesses and mental health problems, you don't have science or investigation. Only thing you have is the way you talk and listen. The way you talk and listen will result in building a rapport or not. If you can listen and build a rapport, the child will tell his or her problem. So depression, this you have to by heart. I mean, every general practitioner should by heart how to diagnose depression. It should be bread and butter today. So the core symptoms are persistent sadness, inability to feel happiness, and reduced energy. So I think most of us know what these core symptoms are. The issue is we really don't know how to elicit this. So I know there are non-single speaking audience here, but try to practice how to elicit these illnesses with using your language. Identify key questions that you can ask from your patients to elicit these symptoms. Say how to elicit sadness in a person. So if you can ask sensitive questions, they will start talking. And you may be the first person they have talked in their lifetime about their sadness or that they can't feel happiness. And how to question reduce energy. So you should have your own set of questions to elicit these symptoms. But if you have good questions, you will be able to diagnose depression very quickly and very correctly. And other four symptoms are feeling worthless, the pessimistic thoughts, what we call negative thoughts, hopelessness, suicidal ideas, feeling of guilt, poor attention and concentration, which lead to memory loss, so poor food performance, anger, low self-esteem, sleep and appetite. So if you have two major core symptoms and three other symptoms, you may diagnose depression. And if you suspect depression, start treatment. You don't have to refer to a psychiatrist or a mental health doctor. Just start treatment. So when you start diagnosing and treating, you will become experienced. And research findings suggest even up to 30 to 40% presentations to GP practices are due to mental illnesses. So your patients will benefit. So treatment-wise, our first line treatment is SSRI. Fluoxetine in Sri Lanka, we have only the 20 milligram capsule. Sertraline, of course, we can start children, we can start 25 milligram and go up to 50 or increase up to 200. Fluoxetine or sertraline are the most researched medications for fluoxetine and sertraline are the most researched medications for children. And citalopram, those are the SSRIs that we usually use for adults. When the vaccine, again, second line for adults. So I suggest that you start with fluoxetine and sertraline, fluoxetine or sertraline. And if it does not respond in a child, you refer to a mental health specialist. Start with lower doses in children. And if you are not comfortable with treating depression in children, refer to a psychiatrist. But adults, go ahead and start. So in an adult, you can start fluoxetine 20 Wait for about 2-3 weeks. If there's response, continue. If there's poor response, you can increase to 40. Maximum dose of fluoxetine for depression in adult is 40. Sertraline you can increase. Fluoxetine has some problem with diabetes, so if there are medical problems, you can start sertraline, and you can start citalopram or acetylcholine. If it is not responding, you can try the venlafaxine, or if you are not comfortable going to venlafaxine, prefer. I don't recommend general practitioners start in third line, the imipramine. When it comes, if you need to start a third line medication, I think the patient should be referred to a specialist. Same with mirtazapine. And also remember that the first episode depression is treated only for 6 months, 6 to 9 months after recovery. Patient should not be treated more than 9 months, and at least they should continue treatment for 6 months. Do you have any questions? Yeah, I think starting fluoxetine in children, very small children, is now in Sri Lanka is the issue because we don't get fluoxetine 10 milligram. We have to give straight away 20 milligram. One issue with giving SSRI in any person is that initially it increases serotonin level in the body and it can lead to anxiety. So we cover with the benzodiazepine, small dose of alprazolam for about a week. And if the patient becomes very agitated, don't give more than 20 for children. If the patient become more anxious, if the child become more anxious or agitated, you have to refer to a specialist because it can cause serotonin syndrome. So, but sertraline, of course, you can start 25 milligram. 25 milligram is available in Sri Lanka, and you can increase to 50. So that may be a better safe option initially. If you discontinue, for say patient recovers and they stop medications after about a month, nothing will happen. But what the research says that the relapse rates are higher unless you continue for 6 months. Okay, so over the past years, what we have experienced is our doctors are getting more and more competent in diagnosing depression, but not the same with anxiety disorder. So still primary care physicians or even secondary care physicians fail to diagnose anxiety disorder because the presentations are physical, like dizziness, so that may mimic ENT problem, burn in tummy, that may mimic gastritis, pound in heart, that may mimic cardiac problem, sweating, dry mouth, sort of breath, that may mimic respiratory issues, tension headaches, that may mimic migraine. So again, if you get these things, remember that anxiety due to sympathetic and hypothalamus pituitary gonadotrophic corticoaxis can lead to these symptoms. So just check whether they are worrying all the time, whether they are stressed, whether they have fears or phobias, anger, and whether they have this collection of anxiety symptoms. So usually what we fail to diagnose is this generalized anxiety disorder where the people are worrying all the time and they are getting these symptoms. So just ask them whether they have other kinds of anxiety as well as whether they worry all the time and that whether that worrying is a problem to them. And some comes with panic attacks. Panic attacks are easy to diagnose if you know what to ask. Usually panic attacks they explain that they get severe chest tightness, difficulty in breathing, lightheadedness, and with the associated fear. The fear is usually that they are going to get a cardiac issue or a fainting issue. And these symptoms last for about only 10-15 minutes. And usually most of them get panic attacks in the night as well. Acetalopram, I don't think there's much evidence for acetalopram in children. To my knowledge, most evidence are for fluoxetine and surgery. If the patient develops sexual side effects due to SSRI, main side effect is delayed ejaculation, then you may have to think of mirtazapine. So if you are confident in antidepressants, you can try mirtazapine, but if not, if they develop sexual side effects, you can refer to a specialist. So anxiety disorders, again, managed by talking to the patient, and you encourage them to enjoy the life, start enjoying life, and start getting more hobbies into their life. And then you can expose them to things that they avoid. And again, anxiety disorders are treated with SSRI, fluoxetine, sertraline, acetalopram, that medication. So again, as I said, we don't see much general practitioners diagnosing anxiety disorders. So again, suspect them, especially now a lot of young adults come with anxiety disorders. Key question to ask them whether they are worrying all the time and whether that worrying is an issue to them, and give a trial of fluoxetine or sertraline, and they will come with very good results. Especially people who get angry easily, we see that they are very anxious. And if they come with anger management problems, I usually try a SSRI and it works in most of the time. So start diagnosing anxiety disorders as well. I'll go to the second presentation. 42-year-old housewife comes with aches and pains, non-specific symptoms for 6 months, poor sleep, and there are repeated presentations. Now, here is the challenge you and me face. Now we have worked, so if we are talking about Sri Lanka, we have worked till 4 p.m. in the hospital and we go to the private practice, and then around 9:30, this lady comes again and again complaining of aches and pains. And when she starts talking, she doesn't stop. She goes on talking about her aches and pains, and we want to get rid of her, and we prescribe some medications and send her home. But again, she comes after some time. Now, one thing we have to stop and ask is whether she has a problem. Sure that we have a problem. When somebody comes and tell us a lot of pains, aches, that we know it is not due to it doesn't tally with the organic issue, and we have to listen. We have a problem. But then we have to understand that she has a problem as well. She has a problem. She may not know what is the problem is. The only way she can elicit her problem is through somatic complaint. So one thing we can remember always is what Hippocrates told us, that we can cure sometimes, we can treat often, but we should try to comfort always. So please take time to listen. Just listen and stop writing. I mean, writing means as soon as the patient starts telling things, we say, don't worry, or there's no big problem with you, or give some medication. So stop writing and start listening. I know in a busy general practice that may not be easy as said, but then only way to help your client may be listen. So again, key areas is she's middle age and she's a housewife, and there is repeated presentation. Now, when you come to middle age, the bigger issues we have identified is the border. Now you have lived a lot of your life. The more glamorous period is over. There are a lot of responsibilities and very few rewards. So you may start working from about 4:30 a.m. and you go on working, and you can't stop working because there are a lot of responsibilities, but you get very little reward. So when it comes to a housewife, this may be a relationship problem with the husband or kids. There may be marital problems, domestic violence. So repeated presentations because she is not getting the support she wants. There are some ongoing problem, and it would be easy if it is due to mental illness because we can just give some medication and she will get better. But if it is not due to mental illness, if it is due to a social problem, only thing we can do is talk to her. So what I suggest is some of you may have undergone training in counseling, some may not. And these are techniques you can learn from YouTube videos. So I suggest you learn active listening. So how active listening means? Listening means listening to somebody, but the active part is the difficult part. Active part is you have to concentrate very hard to understand what she is saying and what she is not saying. You have to understand to stop and ask critical questions, so that you have to be very actively concentrate on what she is talking. You have to understand the emotions, and then you should know what questions to ask to bring out the emotions, say sadness or anger. So, and we have clients say that if the therapist or the doctor know how to listen actively, most of their problems goes away. So that's why this counseling is thriving, because not because counseling find uh, find answers, but because they know how to listen actively, clients get a lot of help because they can pour out their problems and the emotions. Also learn something about marital counseling. I suggest systemic marital counseling. If you Google marital counseling, you will see techniques. They are small but they are simple but successful techniques for marital counseling. Same for sex counseling. If you are confident, ask about sexual life. Most of when they come to middle age, they don't have a good sexual life. And again, there are techniques that improve your sexual life. You can learn them from Google and start using them. Again, how to manage boredom. Again, I think that you have to think. You will not find answers in Google. But I suggest to my clients are that try things that you enjoy before, or try new things and see whether they work. I mean, experiment new things and see whether they work. I mean, start reading a book, start going to a film, or start going to a trip, start doing some hobbies, and see whether they work. And of course, if it is a middle-aged woman, always ask about domestic violence in private, whether their partner abuses them physically, emotionally, or verbally. If domestic violence is there, again, what you can do is listen to them. And if it is unsafe, if you feel they are unsafe, you can have a safety net, like they can call uh, the police anytime, they can shout, like, so you can discuss a safety plan. And if you think if the client is at risk, you can refer to the hospital or Mitru PSO or someplace in the hospital. But always ask for domestic violence. And in domestic violence, we try to give the decision-making ability to the client. Any questions? Okay. We have come to the third presentation. A 43-year-old man is brought in by wife. And the issue is he's taking too much alcohol. And the man says, I don't take much alcohol. It's her issue. So how do you respond to this? So another thing I want you to do is go and study motivational interviewing. There are good Google, YouTube videos in motivational interviewing, because we do things to achieve something. Say a patient doesn't take diabetic medication. And what we usually do is we call them or tell them that you are going to die and or anything and try to scare them. Our goal is to make them take medication. But scaring them, scolding them, you may know that does not lead them to better compliance. So research evidence show that motivational interviewing is the best method to achieve these goals, like taking medication, so improving compliance, changing a habit. And the techniques are easy to practice, easy to learn, easy to practice. There are good YouTube videos how to do motivational interviewing. And if you practice motivational interviewing, you will be able to make your clients more happy and achieve the goals as well. So this is something that we don't offend the client. We don't push them to do things. And our objective is to help them. And we tactfully win his confidence. And what we do, again, we try to understand what he says and we don't jump to correct them. See, if he says, I don't take much alcohol, but it's wife's issue, he's trying to say something. So our next question may be, okay, I hear what you say that it's wife's issue. So would you like to tell me what the wife's issue is? So then he will start talking. And then we will understand that we will appreciate his problem. So gradually we may be able to win his trust and make him see how the problem he has is related to alcohol. And this will yield more better results than just jump into the alcohol problem, where he will become very resistant to your therapy. Coming to alcohol, or any other substance, we have three categories for alcohol. We have alcohol dependence category, about 3% of the population. Harmful drinking category, about I think 19%, and social drinking. Now, you have to remember that there's no longer a safe limit in alcohol. In 2022, I think WHO disregarded the safe limit thing. So any amount of alcohol is unsafe. So what I request from you is, you may have your private preferences, but do not endorse or promote alcohol among your patients, because they respect what the doctors say. For example, you may know the best evidence-based method to stop smoking is the doctor saying the patient to stop smoking. The only message, the message, small message the doctor saying to the patient stop smoking has proven to be the best evidence-based method for quitting tobacco. So do not endorse or promote alcohol ever on your patients. Always say, according to the research, that any amount of alcohol is unsafe. So dependence is an illness. Alcohol dependence is a mental illness, and it has symptoms. So you have to know these five, six, five symptoms. They will have withdrawal symptoms. They will complain of withdrawal symptoms. They will complain of tolerance. That means that they have to take more alcohol to come to a previous level, and they have no control of drinking. They will start around in the morning or afternoon, anytime. They have no control over drinking. Or they will say that as soon as I take a drink, then I take alcohol for 3-4 days. I can't stop. There's a strong desire, craving for drinking, and then they neglect other alternative interests. They are only interested in drinking. So if there are three symptoms, you can diagnose alcohol dependence. So withdrawal symptoms are, they will develop tremors, sweating, insomnia, nausea, vomiting, agitation. If they have only these symptoms, I think it's safe to treat them at the primary care level. More major symptoms are delirium, where they get scared, they see visual hallucinations, get auditory hallucinations, and develop fits. So if the latter two are there, that's called complicated withdrawal. That you can't manage in primary care. That patient has to be admitted for detoxification. Otherwise, you can, if they don't have these symptoms, you can detoxify them in the primary care. So management of non-complicated withdrawal, we usually do by chlordiazepoxide or diazepam. So chlordiazepoxide, we usually use 20 milligrams 6 hourly. If you go diazepam, you have to divide that dose by 2.5 to come to a diazepam dose. And you have to give thiamine 100 milligrams 3 times a day. So you can manage withdrawal at the community. You usually give a higher dose in the first day and tail it off. And tail it off over about 5 to 7 days. I don't know about vitamin B complex. What we are giving thiamine because of this Wernicke's encephalopathy. So I don't know about vitamin B complex, but thiamine you have to give, especially if it is complicated withdrawal, you have to give IV thiamine. So the patient has to be admitted. Yes, thiamine oral and non-complicated also we give about oral 100 milligrams TB. The GP level, thiamine and diazepam, that's the dose we recommend. If you want further reading, I will give some websites for further reading. And also you can read the mostly prescription guidelines, mostly MAUDHLEY, mostly prescription guidelines. They give the exact doses for thiamine and diazepam at primary care level. End of the slide, I will give some websites where you can get more doses. And the other thing is you can get the Medscape app now. It's very easily available, the Medscape app to your smartphone. And if you have that app, you can have to just type the medication and it will give all the doses. So if you have smartphones, download the Medscape app to your phone. Relapse prevention for alcohol, I usually use disulfiram. It's a deterrent. Like I start with 500 milligram. They can't take alcohol because it will cause side effects because it increases the aldehyde level. But then there are anti-craving medications like acamprosate, 666 milligram TDS or naltrexone, which is bit expensive. Always there are psychological interventions, even topiramate you can use, but I use disulfiram. You can try relapse prevention medications at primary care if it is non-complicated alcohol dependent. Another thing I suggest, yeah. Any question? Another thing I suggest is you go and read the brief intervention. So there are a lot of things you have to read. Brief intervention is a small booklet published by WHO. I think the old one is the best one. And I will send all the brief intervention booklets to Pipi and Nishad. So if anybody wants, you can get it from them. It gives a nice way how to talk to a patient with substance abuse and give them small works so they can get over their habits, like identifying alternatives, identifying what triggers their behaviors and finding alternatives for that trigger. Usually, my thumb rule is if they spend 4 hours of their day for alcohol, and if they stop, they have to find alternative pleasurable activities to fill that 4 hours. So if they don't have alternative pleasurable activities to fill the 4 hours, there's no point of them stopping alcohol. So that's the key message in brief intervention. So again, come to a rule of find and test alternative pleasure. I think that's all. And these are some videos we have done. Our non-communicable diseases website, Sri Lanka, has YouTube videos done by College of Psychiatry for primary healthcare physicians on covering all the mental illnesses. So if you go to this site, the videos will be available. And Mental Health Directorate also has a booklet about managing mental health problems in primary care. So you can go there also. Any questions before I wind up?
Dear sir,
Yeah.
there's another question at the beginning of the chat uh, that the starting dose and continuation of doses for children and adults for SSRIs
Yes.
and the
So
duration.
yes, I mean for children again try the Medicaid, but usually I look at their weight and build, and if their weight and build is not big, I start sertraline with 25 milligrams and see them after about 2 weeks and see the progress, and if I might increase to 50. What I am worrying here is the serotonin syndrome. If they are well built, I give them fluoxetine because we don't have fluoxetine 10 milligram in Sri Lanka. If you have fluoxetine 10 milligram, you can start with fluoxetine 10 milligram. As we don't have fluoxetine 10, I give 20 for children with well-built children. I give fluoxetine 20. Adults, we can start 20 straight away with a small dose of diazepam or alprazolam. Sertraline again 50. SSRI again there's a caution in elderly because SSRI can lead to hyponatremia. So again, I might give a smaller dose if they are elderly, over 70. But adult years, you can start straight away with 50 or sertraline 50 or fluoxetine 20. Can pseudoseizures be an anxiety manifestation in children? Pseudoseizures we have seen pseudoseizures as a conversion disorder that due to a stressor or a conflict or part of depression, or it can be part of anxiety as well. But pseudoseizures has to be diagnosed by a consultant because sometimes it's very difficult to diagnose a pseudoseizure from a true seizure. And even the experts sometimes split their hairs. Neurologist saying this is a pseudoseizure and the psychiatrist saying this is a true seizure. So I suggest if there are pseudoseizures, always refer to a mental health specialist. Yes, but to answer your question, yes. Postpartum depression, I use fluoxetine. Again, postpartum depression, because of the seriousness attached to postpartum depression, I think should be managed by a mental health specialist because there's a lot of risk there, not only suicide risk but harm to the child as well. And postpartum depression has to be closely monitored and followed up by the midwife. So I suggest that you refer to a mental health specialist. I don't know, in Sri Lanka at least, most of the more postpartum depression come to the specialist. Okay, there are no other problems. I will go back to the area. So in a teenager, if there's a clear deterioration and if the child gets angry easily, please exclude depression because we get very disastrous results these days. And always look for parenting. If you find parenting issues, try to correct it. And as you know, Sri Lanka again, we are having higher rate of suicide and 50% of them are due to depression or more. And the best way to manage depression is diagnosing and being managed in the primary care. Second thing, start diagnosing anxiety disorders. and treat them and see. Especially if they are getting angry, if they are stressful, and if they are getting this collection of anxiety symptoms, start diagnosing and treat. And with success, you will get confidence in diagnosing anxiety disorder. I mean, what anxiety disorder means, what I am more worrying is about the generalized anxiety disorder. And substance, read about motivational intervene and brief intervention, because you can do a lot for substance intervention as general practice. Okay, if there are any more questions, I will stop there. Thank you.
Dear sir, and dear all, yeah, we as a team would like to invite our regional chair. I suppose Dr. Kingsley Boothi is online. Hello.
Yes, I am. Yes. Thank you,
Yes,
Pranay.
yes. I cordially invite you to attend our webinar and give a thanking talk and a brief ending talk to the webinar. As a regional chair, I would like you to invite to the last talk.
Thank you so much, Dr. Burnett, for inviting me.
Yeah, could you please open your video? Yeah.
Yes. Okay, thank you. Hello, good evening, everyone. Thank you, team, for inviting me to witness this very insightful and comprehensive talk to celebrate this World Mental Health Day with the theme Mental Health at Work. We're very lucky to hear from a very experienced psychiatrist in Sri Lanka, Dr. Prava. Thank you so much for your very comprehensive and insightful sharing of knowledge on the common presentations at our GP clinics, mainly depression, how to address depression, anxiety, and substance disorders. I was quite intrigued by hearing more about the active listening and motivational interview, which can do lots of help to the patients apart from the pharmacological management. And thank you so much, sir, for answering all the questions and enhancing the knowledge of our GPs. And last but not the least, thank you, team, and Spice Rich Sri Lanka for organizing such a profound webinar. Thank you so much. Good night.
Thank you, Kingsley. As a conclusion, I would like to share the certificate for our sir, who has given a remarkable webinar to all of us. This certificate could carry some CPD points for our sir. I suppose you can see the certificate.
We can't see.
Yeah, sure.
Still opening, yeah.
It's still loading.
Okay. You okay now?
No, we can't see.
There is some technical thing.
Yeah, off your video, please, Pranay. Then maybe the internet issues.
Okay, Govit. Thank you. Very sorry for the disturbance.
Now we can see.
Yes. Okay. Thank you, Vi, joining me for the webinar, and all of the participants who have had a good capacity and tolerated the 1 hour, and you got something fruitful, I suppose, commemorating our day today, Mental Health Day 2024. And suppose to continue with such a wonderful things in future as well. So thank you, sir. Thank you all for joining for the webinar. So shall I make it a day today? Thank you all.
Thank you
you.
all.